Morning, Miss Silk.
Good morning.
I wish it'd warm up.
Me too. Can you guys see that okay?
Yeah, I can see it.
Yeah, I can see it.
Perfect. Okay, you guys, we've got like another minute before we start here, but so just so you're aware, this is the topic we're going to go over today here, and I'm going to go over a little bit of math with you as well for the test on Thursday. And then I just want to tell you ATI chapters for this stuff that we're talking about today would be chapter 53 and 54, I believe. Yeah. So if I had to guess, there's probably about maybe 10 questions, if that, from this stuff I'm going to go over today on the test. Okay, so we're going to go ahead and get started. It's 9 o'clock, so. All right, so the gallbladder. There we go. All right, so I put this picture on here so you can kind of get an idea of where it's at and kind of what it does. So you know how we just talked about the liver last time. So here's your liver, remember, right upper side of your abdomen. And then right underneath that is your gallbladder. It's this really tiny little pear-shaped organ. And then you're also hooked up to the common bile duct, which helps, supply the liver with, blood and stuff. And it also will, be like a way of transporting bile as well. Okay, so anyway, so the gallbladder has an absorbent lining that helps to concentrate bile that's being stored in it. So when food enters into the small intestine, after it goes all through everything, a hormone is released and it signals the gallbladder to contract and secrete bile into the small intestine through that common bile duct. So bile would go from the gallbladder through the common bile duct into the small intestine. All right, so when we talk about bile, it's composed of a bunch of things. So it has water, electrolytes, lecithin, fatty acids, cholesterol, bilirubin, and bile salts in it. The bile salts and cholesterol help to break down fats so they can be reabsorbed into the portal blood for return to the liver. So another important function of the bile is it helps assist remove waste products. So this part of that's the bilirubin. So it helps get rid of that out of the body into the feces. If the flow of bile is impeded in any way, bilirubin does not enter into the intestine like it should, and then blood levels of bilirubin will increase. And this causes changes that produce some signs and symptoms of gallbladder disorders. So that's when you would start seeing like the jaundice and all of those other crazy things. All right, so with bilirubin, this is a brownish, orangish, yellowish color. So if the gallbladder is not releasing this bile properly, the stool will look light pale or clay colored. That's why, when we talked about all of that stuff with the liver, if the liver isn't working right, this is part of that. So your stool isn't going to have the color that it normally does. It'll look, light pale or clay colored. also with the stool, if you're not like breaking down the fats like you should, then you're going to have like fatty looking stools, and that's called steatorrhea. So I can spell that for you in case you don't know how to spell that. It's Steatorrhea. So anyway, what normally would happen then, your gallbladder would squirt a little bit of this bile into the duodenum after, stuff comes down through your system in the form of chyme. So it squirts that bile in there, and then the bile would travel down the cystic duct into the common bile duct into the duodenum. So this bile is what would help digest those fats. And it also helps the bilirubin leave the body to go out through the stool. Like that's what it's supposed to happen. So if you have a gallbladder that is not working right, if it's inflamed, if you have cholecystitis, which is what we're going to talk about here in a second, it's not going to drain the bile properly. So your bile is going to become really thick, and it's going to lead to increased pressure in your gallbladder. It's going to lead to inflammation and damage of the gallbladder wall. And this inflammation can cause other things to inflame, like the pancreas too. So it can cause all kinds of problems. Blood flow can also be compromised to the gallbladder and lead to death of the organ, if you have too much inflammation going on. So it's a huge deal. So when we say cholecystitis, we're talking inflammation of the gallbladder, and this can be acute or chronic. So as far as signs and symptoms go, if you think someone has this, typically they're going to have pain in their right upper abdomen that radiates into their right shoulder, which always seems weird to people, but yeah, it always goes to the right shoulder. You would have tenderness, rigidity of the abdomen, and also probably some nausea and vomiting that goes along with it. You may have a little bit of a temperature. And then I don't know if you guys remember talking about Murphy's sign forever ago, but if you were doing Murphy's sign with your assessment, remember you have the patient take in a deep breath and hold it while you're palpating that area of their abdomen. And then pain would occur when the inflamed gallbladder comes into contact with your hand. And then they would like gasp kind of funny. And then you would know that it's positive Murphy's sign. So that would be kind of indicative of cholecystitis. Okay, so on this slide, I also put some possible causes of why you would have this. And this probably isn't everything. It's just, what I have on here. So stone formation is a big cause. So a lot of times it's because you have gallstones. You could have like an E. coli type of infection going on. You could have, a tumor of some sort, adhesions, any of those things. Okay, so a lot of people will have gallstones, right? So cholelithiasis is another name for gallstones. So presence of stones in the gallbladder. So when you have this, you are going to have symptoms like you're going to feel really full, like your abdomen's really distended. You're going to have a vague pain in your right upper quadrant after you consume a meal high in fat. That's like a real key here. So risk factors for people, to get gallstones, people who would be more at risk. This would be women, people who are obese, usually older adults. It's not always older adults, but it can be. Family history of it. If you're pregnant, which I think is interesting, right? And then Native American or Mexican American people are more at risk for this. Okay, so again, there's a ton of other, causes or possible reasons why you might get this. We already mentioned the obesity and being female and being pregnant and stuff. But there's other stuff that are listed here too. So, you know, maybe you're on low dose estrogen therapy and that's causing you to have this. Maybe you have cystic fibrosis or something along those lines and that caused you to have this. I don't know, there's a ton of reasons here. So one thing I want to talk about real quick before I get into this slide here. Sometimes when people will come in for cholecystitis, they actually have an infection going on of their gallbladder. So how does the gallbladder get infected? So your gallbladder connects to the liver by that, you know, common bile duct that we showed you in that picture a few minutes ago. So if a stone blocks the duct, bile backs up and causes the gallbladder to be inflamed. So that's that acute cholecystitis. So your gallbladder would swell and become red. And during this inflammation process that it's going under, you're going to get a buildup of fluid inside of the organ, and this can develop a secondary infection. So that's kind of how you get that. All right, so again, you know, that's probably 9 times out of 10 what's going to happen is you're going to have some kind of obstruction of that duct and you're not going to have bile that's flowing like it should. So some of the common things that you would see that go along with this obstruction of your cystic duct would be pain and biliary colic. So when this gallstone obstructs the cystic duct, your gallbladder gets distended, inflamed, infected, like we were just talking about. You can kind of have a fever associated with this. Right upper abdominal pain that radiates to your back and your shoulder. That's that pain and biliary colic. So the jaundice you're definitely going to have, and this is associated a lot of times with that pruritus, which is itching of your skin. You're going to have changes in your urine and stool color. So remember, we already said your stool color would be pale and clay colored, and your urine's going to look really dark. And then vitamin deficiency, you'd also have this going on. So all of this that's going on with your gallbladder is going to interfere with your absorption of fat-soluble vitamins. So you're not going to be able to absorb vitamin A, D, E, and K. So if they think that you have this issue with your gallbladder, there's a ton of different imaging studies that they can do for this. Sometimes they'll just start out with a regular abdominal x-ray, and this is going to help exclude other symptoms because maybe it's not your gallbladder, maybe it's something else. They may go to an ultrasound. The ultrasound can detect a stone in your gallbladder, so that might be the next thing they might do. The radionucleotide imaging, or cholecystography. This is a test that you would do in nuclear medicine. They put a radioactive agent into your IV, and they watch how that's taken up by the liver cells, the hepatocytes, and then it's excreted rapidly through the biliary tract, and it's going to help them diagnose if you have cholecystitis or not. There is something called a HIDA scan that they can do. That's going to detect gallstones and assess the ability of the gallbladder to fill and concentrate its contents and contract and empty like it should. This ERCP, the endoscopic retrograde cholangiopancreatoma, I can't say it. Anyway, the ERCP, this is another test that they could do, which is, they do a scope basically, and they get in there and they look at everything and see what's going on. So they do have the ability to remove stones during this procedure. So it's kind of a nice procedure in that way that you could actually do something. It's not just diagnostic. And then there's another percutaneous transhepatic cholangiography. That's another one that they could do. Okay, So believe it or not, if you come in with gallbladder issues, sometimes they'll actually like just medically manage you. So it kind of depends on how bad your symptoms are. If your symptoms are extreme and they're really bad, then of course they're going to go right to surgery with you. But if not, then usually they're going to try and get you to like relax for a little bit and um, give you IV fluids and maybe put an NG tube in, treat your pain, and maybe give you antibiotics for a while. A lot of times this will help and you won't even need to go to surgery. So that could be a route that they take. Other things that they would do to medically manage this, they would want you on a low-fat diet. And sometimes they'll do a liquid diet at first. They want you, when you do go home, to avoid eating things like eggs, cream, pork, fried food, cheese, rich dressings, gas-forming vegetables, and alcohol. So they want you to avoid all of those things. And then there are a couple of medications that they could do. Like not everyone is a good surgical candidate. So if that was the case, maybe they would put you on one of those medicines. And then analgesics, maybe they're going to, send you home on some kind of pain medicine, for a while to get you through. So some of the gas forming foods that we want to stay away from would be beans, cabbage, cauliflower, and broccoli. And then other things we would tell this person, we want them to, promote weight reduction. So if they could lose a little bit of weight, that's going to help them a little bit. Instruct them to take fat soluble vitamins. So again, so this wait and see approach with this cholecystitis, sometimes this is done by surgeons because maybe they do plan on doing surgery on this person, but they want to wait and like let their gallbladder kind of calm down a little bit, treat some of that inflammation and get it down so that when they do take them to surgery later on, that it's easier to mess with what they need to do, and they're not going to hopefully not going to mess with that bile duct and have an accident with that. So a lot of times they'll delay surgery for about 6 weeks with people. So they say, if you take you right away, sometimes you have a higher complication rate, and they're worried about risk of injury to that bile duct because of all of this inflammation that you have going on. So sometimes, waiting is better. So with these medicines that I have listed here, these medicines would be mainly for people who are not going to have surgery. So what they do is they help gradually dissolve the stone that this person might have. So if this person has stones, so the bile acid gradually dissolves the cholesterol-based gallstones. And then this person would need to have ultrasounds every 6 months during the first year of taking that to make sure that this was working. So that would be something that they would have to do. And it's these medicines here, this Actigol and this Chenix and stuff. So there are procedures that you could do if someone was not a surgical candidate, So like, again, you could do the dissolving of the gallstones. So there is a procedure that you could do where they put solvent through a tube inserted percutaneously into the gallbladder. And this solvent is supposed to like help dissolve these gallstones. So that's something that they could do. And they would do this through that ERCP test. They could always do a stone removal by instrumentation possibly as well. So again, this would be through that ERCP. So they have like these different tools that they can put on the end of that scope that they could go in and like, take a stone out if they had to. So that could be a possibility. But sometimes the stones are stuck in a certain place and it's just not feasible to get them out this way. And then also there's 2 different types of lithotripsy. There's intracorporeal and extracorporeal. So intracorporeal is where they do a laser pulse technology through an endoscope. So like Again, maybe it's the ERCP, you have the scope in, and then they have a certain attachment that they put on it, and they're going to do this pulse laser treatment inside your body, and then that's going to break up the stone. The extracorporeal shockwave therapy is where you, my understanding is you lay on a fluid-filled pad, like, so maybe there's a, like a table that you lay on, and they have this fluid-filled pad on it, and then this pad kind of delivers the shock waves through your skin. So you may have a little bit of pain during the procedure because of the movement of the stones, but other than that, it's generally not too bad. All right, so when we do the surgery, it's called a cholecystectomy. So this is removing the gallbladder by either laparoscopic or an open approach. So, typically you would always love to do laparoscopic instead of open, because you're going to have way less risk factors and way less problems after the surgery. So like if I just have little tiny incisions compared to like a huge incision, then I'm going to have less chance of infection. I'm going to be able to get up and move around a lot quicker, and I won't have as many restrictions. Generally, you can, go back to work quicker and all that kind of stuff. There's a lot of pluses for laparoscopic. So generally, that's the way that they do this surgery. They do that more often than not. So laparoscopic, they put a scope in through like the belly button, and then they have maybe two or three other incisions where they use their instruments to do stuff. So the gallbladder's taken out, and the bile and the stones are aspirated out. And this approach does not cause a paralytic ileus like the open approach does. So again, there's another plus. Again, the patient usually has less post-op pain. They can be discharged that day, and they can resume normal activities in 1 to 2 days and go back to work in a week. Now, sometimes when they go to do it laparoscopic, they have to convert it to open because they run into a problem. So if this is the case, it's because there's a lot of inflammation around the gallbladder, and it's hard to get it out the way that they were trying to. So then they would have to convert to an open. So if that's the case, then unfortunately you're going to have to avoid heavy lifting for 4 to 6 weeks. You're probably going to go home with some kind of drain in, could be a Jackson Pratt or a T-tube. If it's a T-tube, it will be removed in about 1 to 3 weeks. For T-tubes, you want to report any absence of drainage, because the T-tube, you are going to see bile in that bag, and that's what you want to see. So if you don't see that, that's a problem. It's saying that you're not draining your bile like you should. So the physician would need to know, and they would have to do something about that. Typically, this person would be in the hospital for a little bit longer. So, 1 to 2 days, sometimes longer if they have complications. All right, and then speaking of complications. So the biggest worry for this surgery is that you're going to injure this bile duct. So this is a rare but potentially fatal complication. So when inadequate amounts of bile are not drained from the surgical site, oh, I'm sorry, I'm looking at the wrong thing. So anyway, the bile duct injury, this can cause ischemia, gangrene, a rupture of the gallbladder. It's like a big deal. So that's what surgeons are most worried about here. So that could be, a big deal. So you're going to have to do broad spectrum antibiotics. This would require a surgical intervention if this did happen. It's a huge deal. Now, the bile peritonitis would be, something that could happen. So if, something inadvertently got, opened, bile could drain all into the cavity around. So again, this is rare, but potentially fatal. So inadequate amounts of bile are not drained from the surgical site, and then you would monitor for pain, fever, jaundice, and report those findings immediately. And then the third thing here, post-cholecystectomy syndrome. This is awful. So just imagine you've had all these issues with your gallbladder and you go and you get it out, and then you start having some of those same signs and symptoms again. So what this is manifestations of gallbladder disease occur even after the surgery immediately or sometimes months later. So you have some of the same symptoms even though the gallbladder's gone. Crazy, right? Okay, so this is something that's important here I want to talk about. So older adults always present differently with some of this stuff. And I'm going to tell you about some of the reasons why. So with older adults, they have a cholesterol saturation of bile that increases with age because of the increased hepatic secretion of cholesterol and decreased bile acid synthesis. So they may present with different signs and symptoms of gallbladder issues. So instead of having like the right upper quadrant pain and all of that kind of stuff like they would normally present with, they are going to look super sick. They're going to look like they're in septic shock. So they're going to have things like oliguria, hypotension, changes in mental status, tachycardia, tachypnea. So I would star that in your notes. That's super important. So you're not going to generally be able to pick this out really easy in an older adult. So for them, the risk of death and complications is higher because they have a lot of life-threatening biliary tract issues. Okay, and then with our interventions, so things that you need to kind of pay attention to. So anytime you take care of someone that's had their gallbladder out, you are worried about relieving their pain, right? So we're going to teach them to splint their incision and use a binder after surgery. Sometimes that helps a lot. With their respiratory status, we want to encourage them to do coughing and deep breathing, do their incentive spirometer. With maintaining their skin integrity and promoting biliary drainage, we want to keep the tube above the level of the abdomen. And we're talking like T-tube here. With nutritional status, we want to eat a diet that's low in fat, high in carbs. That's really important as well. So after surgery, low fat diet, high carbs. And then they're restricted from lifting for 4 to 6 weeks usually, especially if it's an open procedure. We want to monitor and manage potential complications. So again, we're going to watch for bleeding, a tender, rigid abdomen, pain, vomiting, or increased temperature, because that's going to show us that they're having a complication. And then for promoting home and community-based care, we want to report to the provider any symptoms of jaundice, dark urine, pale-colored stools, pruritus, signs of inflammation, infection, pain, or fever. So that's the things you want them to tell you if they see any of that starting to develop in home. So they had their gallbladder out, so they shouldn't be seeing those symptoms. So if something like that starts happening, then you know there's an issue. So that's the stuff that we're going to be talking about. Whoops. Sorry, I'm screwing up here. Okay, so the next part of this is about the pancreas. So we just talked about the gallbladder, cholecystitis, now we're getting into the pancreas. Here's a picture of that. So here's your pancreas, here is your common bile duct. This shows you where the small intestine is in relation to that. So it's like everything's real close by here. So the pancreas is an organ that's located in the abdomen as well. It plays an essential role in converting the food that we eat into fuel for our body's cells. So the pancreas has two main functions. It has an endocrine and an exocrine function. The exocrine function is the one that helps to digest foods, and the endocrine function helps to regulate our blood sugar. The pancreas is located behind the stomach in the upper left abdomen. So remember, everything else we just talked about was upper right, so now we're on the opposite side. So with the exocrine function, let's just talk about this for a second. And don't let all of this get you confused. This is just like background information here, so don't worry about this. So the pancreas contains these exocrine glands that produce enzymes to help us digest food. So these enzymes would be trypsin, chymotrypsin, amylase, lipase. When food enters the stomach, these pancreatic juices are released into the system of ducts that culminate in the main pancreatic duct. So the pancreatic duct joins the common bile duct to form the ampulla of Vater, which is located at the first portion of the small intestine. The common bile duct originates in the liver and the gallbladder and produces another important digestive juice called bile. So the pancreatic juices, the bile that are released into the duodenum, help the body to digest fats, carbs, and proteins. So with your endocrine function, remember this has to do with your blood sugar now. So the endocrine component of the pancreas consists of islet cells. These create and release important hormones directly into the bloodstream. So two of the main pancreatic hormones are insulin, which acts to lower blood sugar, and glucagon, which acts to raise blood sugar. So maintaining proper blood sugar levels is crucial to the functioning of key organs, including the brain, the liver, and the kidneys. So again, I'm going to mention a little bit about older adults here. So as we age, we have an increase in fibrous material and fatty deposits in the pancreas. We have a decreased rate of pancreatic secretion, decreased calcium absorption, some impairment of normal fat absorption. So they're, more at risk for some of this pancreatic stuff going on. Okay, so here's where it starts to get important. So we start to talk about pancreatitis now. So pancreatitis, what it is inflammation of the pancreas, right? But what is happening here is we have a buildup of pancreatic enzymes. So remember kind of what I just talked about, some of those enzymes that help digest food and stuff. And these are not drained into the small intestine like they should. So this accumulates and it digests the tissue. So it starts to digest the pancreas itself. This can cause inflammation and it can cause it to become infected. So as the pancreas digests itself, the tissue dies, and then you start to get things like cysts or abscesses that can form outside of the dead tissue. And this can rupture and can cause hemorrhage. It can also spread this destruction to other organs, which leads to internal bleeding and respiratory distress. So it can be a huge mess sometimes. So basically, there is an acute and a chronic form of pancreatitis. And then you might say, okay, why would someone get this happening? What's going on here? So one of the common causes of acute pancreatitis is gallstones. So you see how everything kind of plays a part with each other. So if you have gallstones, that can cause you to have this. With the chronic version of this, some of the common causes of chronic would be alcohol use and genetic disorders. So when you get this acute form, so this can appear out of the blue. It can last for days. It's characterized by this inflammatory process, and some of your signs and symptoms would be severe, constant mid-epigastric pain. It can radiate to your flank area, and it's exacerbated by eating. So with this acute form, you can get this persistent vomiting, the low-grade fever, the hypotension, the tachycardia, the jaundice. And then you can also get a couple of odd things going on. There's something called Turner's or Gray Turner's sign and Cullen's sign. So just in case you don't know what the heck I'm talking about, let me find a picture and show you. Okay, so with Turner's and Cullen's sign. So Cullen's, just think about like a C, like a big giant C. If you think of Cullen's sign, you're thinking about bruising that surrounds the belly button. So like it could be bad, like this over here on the left. It could be a little bit more minor, like some of these over on the right. Now, Gray Turner's sign is going to be more on your flank areas. So you could have bruising there. So again, some of it's like really extreme. Like, I don't know if you see this guy here that's sitting, facing us with his back. He's got really dark bruising on both sides right here. That would be Turner's sign right there. So this is something that is specific to acute pancreatitis, and it could be indicative of possibly like really serious issues. So definitely something you would want to know. Oh, darn it. Okay, here we go. So anyway, those are some of those signs and symptoms of acute. And then with chronic, you're going to get signs that are more kind of similar to some of the liver stuff that we saw. So think this person's had this for a while. So now you're going to see, you'll still see pain, but it's not going to be the same type of pain. It's going to feel a little bit different. They're going to have a decrease in weight. They can have jaundice. They're going to have like the fatty stools, abdominal distension, and they're going to have issues with their blood sugar now because this is showing that their pancreas is not working right. So they're having high blood sugars. So going back to that Turner's and Cullen's sign stuff, what this is a seepage of blood-stained exudates into the tissue as a result of pancreatic enzyme actions. So again, it looks like bruising. So it takes about 24 to 48 hours to develop those signs and symptoms of Gray Turner's. So these can help you predict a severe attack or acute pancreatitis. It can also show you that maybe you have something really severe going on, like you could have a retroperitoneal bleed or something going on. So anytime you would see that, obviously they would do some imaging studies to make sure nothing more serious was happening. All right, with your chronic symptoms, these would be because you have had, persistent attacks of this pancreatitis over a long period of time. So usually more than 6 months. So the pain can radiate from your abdomen to your back. And again, like I said, you're going to see some of those other more significant symptoms because you've had it for so long. Okay, so then with causes. Again, I told you that gallstones would be probably the #1 cause for acute. And then with chronic, you're going to see alcoholism is going to be a really big cause. And then also some hereditary type of things. So you see there's a lot of things that can contribute to pancreatitis. So like pancreatic cancer, you know, maybe you don't know you have that, and lo and behold, that's what caused it. You could have an injury to the abdomen, and that could cause it. There's a ton of things listed here. So just kind of keep in mind the ones that are more common. So when we're trying to figure out what's going on with this person, we're going to be doing labs. And just like you guys did in your one case study, it talked about the pancreatic enzymes and, you know, how it talked about amylase and lipase and all that. So you are going to be drawing those levels. So with amylase, amylase is going to increase within 12 to 24 hours and remain increased for 2 to 3 days. You would have continued elevation that could indicate a pancreatic abscess or pseudocyst. With lipase, this is going to increase slowly, but then it could remain increased for up to 2 weeks. And then I don't know if you guys remember what all of those do, but remember amylase breaks down carbs to glucose. Protease breaks down proteins to amino acids. And then lipase breaks down our fats. So usually if someone has pancreatitis, they're going to have some of those levels elevated. You would also check a blood sugar with this person, because if this person, if you're suspecting pancreatitis, you know, maybe they have issues going on there. You could also do, you know, a couple of these things at the bottom here about the, you know, the CAT scan that might show you a little bit more detail about what's happening with their pancreas. The ERCP is very helpful, just like it was with cholecystitis, because, you know, it's an endoscopy. You go in and you can actually see what's happening in there. So that is a really good way to diagnose. So this is going to assess your pancreas, your bile ducts, your gallbladder. And the nice thing about the ERCP is you can remove gallstones, you can dilate, block ducts by using a stent or a balloon, or sometimes if they have a cyst, you can even drain that while you're in there. So there's a ton of things you could do with the ERCP. And it's not technically surgery, it's just, you know, a procedure that they would do. And then the glucose tolerance test is another one that you could possibly see done for someone that might have this. Okay, so for treatment, generally this is very painful, so you're going to want to give them lots of pain medicine. So we're going to be treating them with analgesics. If they do have an infection going on, which they could, we're going to be treating them with antibiotics. This person usually, like when they eat, it's going to cause them to have more pain. So typically we're going to put them on PPIs and H2 receptor antagonists. So this is going to help, you know, decrease gastric acid secretion. So that would help a little bit. We also want to decrease the pancreatic stimulus. So this means this person should be NPO for right now. We're going to put them on IV fluids. We probably will put an NG tube in. We're going to keep them on bed rest. And then once they start to improve, then we'll up their diet. So once their diet gets upped, it'll be a low-fat, high-carb diet, just like it was for cholecystitis. What else did I want to tell you? With their diet too, you want to tell them to do some type of bland diet. No caffeine, small frequent meals, limit their stress, that kind of stuff. And then again, we want to rest their pancreas to prevent it from being stimulated to produce all of these digestive enzymes. The IV hydration is going to be done because, again, they're not going to be eating for a while, so they're going to be dehydrated if you don't give them fluid. NG tube is done to remove the stomach contents and gas. And then the pain medicine, usually we're going to be giving them lots of that. We don't want to do morphine though, because it can cause spasms of the sphincter of Oddi. And so it can actually cause more pain. And then administering PPIs is going to help prevent activation of the digestive enzymes. So that's why we do all of those things. Okay, so I did want to mention pancreatic enzymes real quick. So certain people who have pancreatitis or have issues with their pancreas have to take pancreatic enzymes. And I don't know if any of you have seen this in clinical before or not, or maybe where you work or something. These enzymes are capsules. They're usually pretty big. And these have to be taken to help digest fats and protein. So you're supposed to take them with a full glass of water. If you had to, you could open up the capsules and sprinkle stuff on food and use it that way. You definitely would want to wipe this person's lips and rinse their mouth afterwards because, again, that's pancreatic enzymes on their lips, and that if you left that there, that could cause that breakdown. Let's see. You need to take these with every meal and also with snacks. You could mix it with something acidic like an applesauce, like if you're going to take it with food, you could do that. You don't want to mix it with anything that's not acidic. So things like ice cream, pudding, stuff like that, that's going to destroy the pancreatic enzymes. So you don't want to mix it with that.
Hey, Miss Silk, I have a quick question.
Yeah.
If someone's on like a tube feed, could they still do pancreatic enzymes? Or like an NG tube or something like that?
You know, that's a good question. I'm not sure if it comes that way. I don't know if it comes in a liquid form. It
Because I
might.
think one of my patients at clinicals was a tube feed, and I thought they took an enzyme, but maybe not. So.
You know, the only time I've ever seen it, it's just been like pill form. So
Okay, that's fine.
I don't know for sure if it comes liquid form because obviously, you know when you open up pills, if it's all those like little balls inside the capsule, that
Yeah.
wouldn't be good to put down an NG tube because you're going to clog it. So if it's powder, that's different because you could mix that with a drink or something, and then maybe that would work. But yeah.
Okay, maybe that's what we did. All right, thanks.
Uh-huh. All right, so again, when they take this pancreatic enzyme, you know this is working if it causes them to have a decreased number of oily stools. So you don't want to see that oily stool anymore. So you want to see like a more normal looking stool. So it decreases that steatorrhea. Okay, so as far as interventions for this person, again, we're going to give opioids for this because it's very painful. We could also use non-pharmacologic methods. We want to put them in a semi-Fowler's position to decrease pressure on the abdomen and also to increase our respiratory expansion. You may have these people on TPN or tube feeds for a while. You know, especially for them being NPO for a while. And then we have to maintain their skin integrity. So we're going to make sure we turn them every 2 hours and watch for infection of their incision. Monitor and manage potential complications. So we're going to monitor their fluid and electrolyte status. We're worried that they could possibly go into hypovolemic shock. So we definitely have to totally keep a good eye on that. And then with promoting home and community-based care. So we want to avoid high-fat foods and heavy meals. We also want to avoid alcohol, which is really hard for some people. So if they have a drinking issue, then maybe you refer them to AA or somewhere like that to try and help. All right, and then as far as diet education goes, again, we want to avoid alcohol and greasy and fatty foods. We want to eat low-fat, small, bland meals, stay very hydrated, and then limit sugar and avoid refined carbs. Okay, so there is surgical management that you could do here too. So chronic pancreatitis is not really something that you go right to surgery for, but if you're really having a big issue, then they could eventually do this. So some of the things that they could do would be a Roux-en-Y, because you remember the Roux-en-Y, they're taking out quite a bit of stuff and reattaching. So maybe the problems, that you're having could be taken care of during that. There is something called a Whipple resection, which I'll talk about here in a few minutes. You could even get a cholecystectomy because it's very closely related to this, right? So if you know that your pancreatitis is caused by gallstones, then maybe that's what you need to have done. And then there's also endoscopic or laparoscopic interventions that they could do. So, and I'm speaking of like that ERCP. There's also a couple other things that the book mentions. There's like a sphincterotomy, which is where they enlarge the pancreatic duct sphincter. There is a endoscopic endoscopic pancreatic necrosectomy, which is another endoscopic thing where they remove some of the necrotic tissue that's in there. So those are some of the other options that they maybe could get done. I'll talk more about this Whipple resection here in a few minutes as we get further. So I don't know if you remember, but earlier on we said that you could eventually end up with like pancreatic cysts and stuff. So pancreatic cysts are these fluid-filled growths that develop in the pancreas. And so some of them can be problematic, some of them might not be. So it just depends on like how big they get and if they're cancerous or anything like that. So most of these cysts are usually benign and they don't harm you, but the time that you would want to do something with them is if they were causing you like a lot of pain or discomfort, So they have a couple of different types. They have pseudocysts, which are mostly made of fluid. They start in or next to the pancreas and are common complications of acute pancreatitis. So that's kind of what we would see most often probably. Then they have serous cystadenomas. These have thick fibrous walls and contain clear fluid. Usually they're benign, but they can cause pain and jaundice and make you feel really uncomfortable. So those would be one you'd probably want taken out. And then with diagnosis and treatment, of course, they would, do some type of imaging to see a little bit more detail about these cysts to see if they need to come out or not. So down towards the bottom here, I talk about how they decide if they're going to take them out. So usually it's best to remove them through surgery, but usually they don't do it if the cyst is not larger than 3 centimeters. So if it's small, they'll just kind of watch it. If it has a solid component, usually they do want to take it out. And then if it affects how you're draining your pancreas and stuff, that's a problem. So you would take it out. And then also if it's growing and causing you pain or pressure. With cancer of the pancreas, we've heard about this a lot lately, especially in the news with different celebrities that have it, like Alex Trebek. It's kind of a sad situation. Cancer of the pancreas is usually caught late because typically you don't realize that you have it until you start to have really bad symptoms, and usually it's too late by then. So some of the big risk factors for getting it would be, usually it's older people, so ages between 65 and 80. A lot of times it's because you have a history of chronic pancreatitis and also diabetes. And then a lot of times cigarette smoking has a big component to it as well. With signs and symptoms of this, again, you're going to have dull, achy abdominal pain, ascites, nausea, vomiting, anorexia, progressive weight loss, jaundice, and clay-colored stools. Now, remember, again, like early on, if you caught this early, you probably wouldn't have hardly any symptoms. So maybe you do have a little bit of stomach pain, but what are you going to do about that? Maybe you think it's nothing, or maybe you have a little bit of nausea and vomiting, but it's not continued. So why would you worry about that, So typically, again, you know, people aren't going to worry unless they start seeing a lot of weight loss and some weird things like that. So to diagnose this, of course, they could, you know, do some blood tests to do like those cancer markers. They could do a CT scan. The CT scan says 85 to 90% accurate in diagnosing pancreatic cancer. So it's pretty darn accurate. And then the needle aspiration. So this would be like a biopsy where they would, you know, biopsy the pancreas. So for treatment, this is where I want to talk about that Whipple procedure a little bit. So generally, like I said, pancreatic cancer you catch really late. So most people, especially all the ones we see in the news usually, they catch it when they're at stage 4. So there's not much you can do for that. Now, you could do radiation and chemo, and a lot of people do that, but you know, whether it helps a whole lot, you know, it might give you a little bit more time, but maybe not a whole lot. And maybe what does it do to your quality of life, you know? So the Whipple procedure is something that you could do, and it's only if, let me get to this other slide here. This is only if you have a potentially resectable cancer. So if they've done imaging and they think that you have it in a spot where they could get it really easily, then they'll try this. So this is a crazy surgery, and wow, is it difficult to go through. So you know how before, and I talked about esophagectomy and stuff, this is like ridiculous. So anyway, with this procedure, it involves removal of a ton of things. So I want you to write this down because this is a test question. So it involves removing the gallbladder, a portion of the stomach, the duodenum, the proximal jejunum, the head of the pancreas, and the common bile duct. So they remove all of those things. And then they do reconstruction and they do anastomosis of different areas, right? So reconstruction involves anastomosis of the remaining pancreas and stomach to the jejunum, and then the tumor gets removed and allows flow of bile into the jejunum. So it's a huge surgery. So with the Whipple procedure, it has a 5-year survival rate of 25%. So I don't know about you guys, but I don't know that I would do that. 25%. And it's named Whipple for the guy who invented this. I guess the first Whipple procedure was done back in 1935 by this guy named Alan Whipple. So that's why it's called the Whipple procedure. It's hard to believe they figured something like this out back in 1935. That's a lot to do, right? But anyway, that's a possibility for someone if they thought that they had you know, maybe their cancer wasn't like really huge and they could get to it easily by this, then they would try this surgery. All right, the rest of this talks about these different types of tumors. There's a pancreatic islet tumor. This develops in the pancreas from a islet cell. Remember, the islet cell tumor can be benign, non-cancerous, or malignant, so it could be either. So depending on the islet cell tumor, an overproduction of certain hormones can result. So an islet cell tumor is rare, but it can cause a variety of symptoms. So one of the types is non-functional islet cell tumors. So this kind of tumor is produces substances that don't cause symptoms. So the only symptoms would be the result from the growth and spread of the tumor. And these are usually malignant. The insulinoma is a tumor that produces the hormone insulin. So insulin's responsible for controlling sugar in the bloodstream, of course, so that would be a problem. So typically, with these signs and symptoms of these, it's going to be kind of related to what's going on. So like indigestion, that would make sense because it's, happening in your pancreas. Increased gas, diarrhea, abdominal pain, yellowing of the skin and whites of the eyes. With the insulinoma, look at your symptoms here. It affects your blood sugar, so it makes sense that you have these symptoms. Headache, lightheadedness, blurred vision, weakness, shaking, irritability, hunger. All right, and then for treatment, surgery is going to be usually what they do for these. They'll take them out. If the cancer is widespread throughout the body, you may need chemotherapy to decrease the size of the tumor. So that's kind of the gist of those. And then on the very last slide, it talks about tumors of the islets of Langerhans. There's something that I guess really secretes a ton of gastric acid. It's this Zollinger-Ellison syndrome. So if you have this, it can cause you all kinds of issues. So typically this person might have to get a total gastrectomy if that was the case. All right, so with this stuff, you guys, like I said, there's probably a total of maybe 10 questions from this stuff, so it's not a ton. Again, I want you to focus more on cholecystitis and pancreatitis than anything. So like that stuff I just flew through, you're not going to have a question on that. Now, I definitely want you to pay attention to diet, like what type of diet people should be on after some of these surgeries. I want you to think about some of the procedures that they do. Like I told you, you have a question on Whipple procedure, so make sure you look at that a little bit. I'm trying to think what else is on there. Do you have questions about anything I said, you guys?
Are you gonna post this one?
Yeah.
Okay, because it was kind of hard to take a lot of notes. I just want to go watch it again and take some notes and write things down.
Yeah, that's fine. All right, so real quick, I want to go over a little bit of math with you because you'll have 2 math questions that are going to be reconstitution math. So I know you guys have never done that before, so let's just do this real quick. Okay, so with reconstitution, sometimes you'll get a med, like, for example, say you're at clinical and you have to give someone Pepcid, or no, not Pepcid, let me think. What is that? Protonix through the IV. So sometimes when you get that, they send it in a vial that is just like a bunch of powder, and it sends you instructions on how to reconstitute it. So you'll have like a paper that you have to look at to see what you have to reconstitute it with and how much. So that's kind of what these problems are like. So like, for example, here's one that says, you have an order for this Clarifen. The order is for 665 milligrams. So I don't know if you guys have paper, but write this down real quick. So my order is for 665 milligrams, and I have a vial of this available. So my vial is just powder, and on my vial, it says it's a concentration of 95 milligrams per milliliter. And then when I look at my paper for, what am I supposed to do to reconstitute this? It says that I'm supposed to reconstitute it with 10 milliliters of bacteriostatic water. Okay, so to do this, I don't know if you guys are, I think a lot of you do this formula method. I'm not sure, but you know how we have that desire over have times supply? Have you guys seen that before?
Yeah.
Okay. So write that down. Desired over have times supply equals the amount that you're going to give. That's what we're going to use for a formula here. So in this particular question, we said our order was for 665 milligrams. So that's going to be our desired, right? So we're going to plug that in there, 665 milligrams. Our have, what we have on hand is what's available. So that's going to be the 95 milligrams per milliliter. So basically, you should have 665 divided by 95. And then your supply, it said we had 95 milligrams per milliliter. So our supply is that 1 milliliter. So if you take 665 divided by 95, what do you get?
7.
Yeah. So our answer would be 7 milliliters. That's how much we would give in this problem. Does that make sense?
What's the 10 for then?
That's just how we get to that. So you don't even have to do anything with that 10 in the problem. Let's try another one. So if we have an order for streptomycin, it's 0.25 grams. And what we have on hand is 400 milligrams per 2 milliliters. So we have to change our order to make sure that that's in milligrams, right? So change the 0.25 grams to milligrams. Okay, so again, you know, our order said 0.25 grams, so we need to change that to milligrams. So what is that in milligrams?
$250.
Correct. So with our formula that we have, we're going to say our desired is 250. Our H for have is going to be the 400. And we're going to multiply that by 2, our 2 milliliters. And what do you get?
$1.25.
Correct. So on the test, I will tell you like how to round it, you know, like maybe I'll say to round it to tenths or whatever. So you would say 1.3 if that was the case, right? So regardless, you guys, in these questions, it'll give you the order it'll give you what's available, and it'll tell you how to mix it. So the how to mix it part is what I don't want you to get confused about, because like in this question, I didn't tell you, it said reconstitute with 9 milliliters of sterile water. So the 9 milliliters you don't do anything with in this, because all you need is the concentration, right? So basically after you mix it with that amount of water, you get this concentration. Does that make sense?
Yes.
So like in that question, it said, you know, streptomycin 0.25 grams was ordered, and you just had this vial of powder. So you open up your paper, and your paper says, oh, mix it with 9 milliliters of sterile water. So you go, okay, you mix that up, and it says for a concentration of 400 milligrams per 2 milliliters. So you want that concentration. So you don't need that 9 milliliters. It doesn't make any difference in you figuring out how much to give. So let's do one more just to make sure you feel okay. Okay, so this one says we have Maxipeme 0.75 grams. That's our order. It comes in a vial with powder. And in our paper, when we open our paper up, it says add 2.6 milliliters of sterile water to mix with that to yield a concentration of 200 milligrams per 2 milliliters. So again, you're going to have to change your order, your 0.75 grams into milligrams, because that's what you have on hand. Anyone figure it out yet?
I got 7.5.
Yeah, that's correct. So that's what the 2 math problems will be like on the test. So I've tried to pick something that wasn't too bad. So again, it's pretty simple if you just follow that formula, and then just don't, you know, get confused about what the directions say. The directions are just telling you how to mix it. So the concentration is what is most important for you, for your purposes. Make sense?
Yes.
Okay. All right, what questions do you have about the test?
I just want to make sure the 3 PowerPoints that it covers is the intestinal, biliary, and hepatic ones, right? Those 3, and then obviously read the chapter on obesity in the book.
Yeah, like I had a little bit of that obesity stuff in that gastric and that gastric PowerPoint, you know, with the peptic ulcers and all that. I had that towards the end. So like you could look at that if you wanted to.
Okay, thank you.
Mm-hmm. What else? Anything else? Okay, well, if no one has questions, I'll go ahead and get off here.
All right. Thank you so much. I appreciate it.
All right, thanks, you guys.
Bye.